Today is about some important topics that can come as short notes or it can be asked as in Viva in your exams. And these are very important short notes, but this is not an exclusive list. মানে শুধুমাত্র এই short note জিজ্ঞেস করা হবে এরকম নয়. These are some very important short notes that I am just mentioning the points which you have to write. There are several short notes in all the chapters, so you have to read the book comprehensively and make some short notes in this fashion for all of them. Because in exam anything can come, there is no such thing as important chapter or important topic, is nothing like that. সব কিছু থেকে কোশ্চেন আসতে পারে, তো কোশ্চেন বানানো বা শর্ট নোট বানানোর টেকনিকটা কিছুটা you can take from these important short notes. Now you have gone through certain disease topics like AIDS that was taught to you last week, then immunizing agents, cold chain, open vial policy, AEFI, immunization schedule. All these chapters are there in your book. Then there is obstetrics, pediatrics, geriatrics chapter, there is nutrition chapter and there is NCD chapter. Now corresponding to this for every topic, you are having a programmatic component, program component that is there in the National Health Program chapter. Just after the diseases chapter, there is the program health chapter. So correspondingly, the short notes can come from that chapter also. For example, for AIDS, the corresponding program chapter contains topics like HIV surveillance, ICTC, which I have mentioned last week, then care, support and treatment for people living with HIV, CST for people living with HIV. Then for immunization, there is pulse polio immunization that can come as a short note, maybe not less chance nowadays, but still pulse polio immunization goes on in the country at least once a year, so it can come. And the more relevant topic nowadays is Mission Indradhanush. Then there is the Obs, Pediatrics and Geriatrics chapter. In that the RCH component, that is the RMNCH component and the geriatric component. So correspondingly there are many short notes that are there in the National Health Program chapter like Janani Suraksha Yojana, JSSK, then Pradhan Mantri Surakshit Matritva Abhiyan, then Suman, Lakshya, NRC, Home Based Newborn Care, IMNCI, RBSK, then INAP, Indian Newborn Action Project, then Battered Baby Syndrome, and then juvenile delinquency, girl, child and gender bias. All these are topics that are there in that program chapter, and you have to compile and make at least 4 or 5 points under each topic and you have to elaborate on them. Then under nutrition, there is short notes can come from the program chapter, that is baby friendly hospital initiatives, Poshan Abhiyan, and under NCD there is the NPCDCS program or the NPNCD program. So short notes can come from any of them. Now the things I've highlighted here are the topics I'll be covering. Along with this, I'll also cover the IDSP, that is Integrated Disease Surveillance Project. Because these are some important topics that can come. We are starting with HIV surveillance. Last week, because we have learnt about HIV AIDS, there is something that needs to be done to monitor the epidemic trends. We learnt last week that there were 3 types of HIV epidemics, right? There are 3 types of HIV epidemics. They are the কি epidemic হয়? Generalized, concentrated, and low level. Low level, concentrated and generalized epidemics of HIV. But how are we knowing that? Because continuously surveillance is going on in the community. So different types of surveillance activities are being carried out in the country to detect the spread of the disease and to make appropriate strategy for prevention and control. There are so many surveillances going on, like sentinel surveillance, sero surveillance, case surveillance, STD surveillance, behavioral surveillance, and integration with surveillance of other diseases like TB. But the most important surveillance of HIV in this country is HIV Sentinel Surveillance. Now we know what is surveillance, that is continuous monitoring, gathering, then the interpretation, analysis, and then taking action on that results by the appropriate authorities, and then starting the cycle all over again. That is called surveillance. How is sentinel surveillance different from normal surveillance? That is, sentinel surveillance itself is a very important topic, and a short note. After the establishment of the fact that HIV infection is present in the population in the wide geographic area, the aim of the surveillance was redefined to monitor the trends of HIV infection. Means we know that HIV is there, now we have to just monitor the trends in the population, that is whether it is increasing or decreasing, or in which groups it is more prevalent or less prevalent, that we have to monitor. Okay, so first of all, where to get this data? A random person won't come up to you and say I have HIV, that they don't do. Okay, a person who will go to do some tests in a clinic will not say that okay, I also want to do an HIV test. That also does not occur, because there is an attached taboo or stigma to it. And secondly, people don't also think like that okay, I should do just screening of my viral antigens and see whether do I have HIV or not. People don't think like that also. So how will you know that HIV is there in the population? Because again, patient can be asymptomatic for 8 to 10 years. How will you know that that person has HIV? So you include the data from the high-risk population through targeted intervention sites and the additional subset of rural samples to antenatal clinics and clinic-based approach. These are the key features of HIV Sentinel Surveillance. What does it mean? Basically, the high-risk population that we have studied last week, they are doing some tests. They had been targeted for screening of this HIV, that is one. Secondly, people who are undergoing regular screening, for example, antenatal population, who are doing their regular screening procedure. One of them consists of HIV screening also. Okay. Then, pregnant women attending antenatal clinics are taken as proxy for general population, that we have learned last week also. And then what do we do for the normal population? Annual cross-sectional survey of the risk group in the same place over a few years by unlinked anonymous serological testing procedures. Means, for example, for other tests the doctor has recommended in the hospital HIV test also. So the person has done that HIV test and the results are there with the hospital for some other purpose. The data has been collected for some other purpose, but what the center, the HIV surveillance is doing is they are collecting that data from all the centers. They are not collecting for the sake the patient ke hamara HIV status janta hobe, that I have to know the HIV status of the patient. That was not the motto behind doing that test. The test has been done for some other purpose in the hospital, the records are there. Those data are then taken up regularly for this surveillance purpose. So the patient, as per say that whoever has done HIV test before, we also do not know, but a data has been collected by NACO actually. This is sentinel surveillance. Okay, this is sentinel surveillance, because through that data only the general population prevalence and the high risk group prevalence and any other hospital based screening results for the prevalence in the population, for example in that area, can be detected. So for example, when HIV testing is carried out without identification of name of samples collected for other purposes, so the positive person is not identified. So all the data that is collected from the hospitals are anonymous. They do not know, we just have to know the surveillance or what is the prevalence of that disease in the community, that's it. We just need to know the number, we do not need to know the identification of who is positive. That is positive, if a person comes positive for HIV, that the clinic will deal with the treatment. That is another thing. But just for surveillance purpose, that what is the prevalence and what is the burden of the disease in the community, only the data is taken up, that how many people have come positive, that's it. Okay. So the number of samples to be screened must represent the risk group under study, and the sample size is determined accordingly. So for example, the Sentinel Surveillance Center or site that is there, who are collecting the data, they need to know how many samples they need to collect for the data collection, so as they represent the total population, that is sampling they are doing. So they need to know the sample size that is representing the risk groups under study in that area. Avoid the selection bias and participation bias. So if someone comes for testing and they are told, for example, when you did research studies in the OPD, you go and tell the patient that we are collecting data for this study, this purpose. আমি এই স্টাডি করছি আমরা, তো আমরা ডেটা কালেক্ট করছি, আপনাকে একটু 5 মিনিট কোশ্চেন জিজ্ঞাসা করব। So suddenly the person, some people will be very afraid to tell the truth. Some people will say no, we don't give consent. Some people will give you consent for data collection, but they will shield some facts. Suddenly there is some participation bias. There is also some selection bias. If you go and select people who are very lean and thin and everything, the interviewer or the data collector himself is selecting very biasly for many other purposes. So all that is avoided through the Sentinel surveillance. We are just collecting the data of the people who are screened for HIV, and among them how many people have come positive. So the percentage of people who have come positive is the percentage of prevalence in that high risk group. That's it. That is for the Sentinel surveillance. So all over India in the Sentinel surveillance round, as per my edition of the book, it is 2016-17 mentioned, but as per maybe 27th edition, it can be a little bit different number of sites. So at the total number of Sentinel surveillance sites were 1323 in the 2016-17 round. It can be more if there is updated data in your version of the book. Okay. So that is the Sentinel surveillance topic is there in the NACP under the National AIDS Control Program. Okay. But this as a separate topic comes in your exam, HIV Sentinel surveillance. So basically, inclusion of data from the high risk population, inclusion of data of the pregnant women in the rural areas as general proxy, rural areas and the urban areas for general proxy purpose for the general population, and then annual cross-sectional surveys of those risk group is done to see the trends of the HIV infection in the population. That is the HIV Sentinel surveillance. So this is basically a secondary data collection. Primary data collection is for a purpose of any original study. If you collect data, then that is a primary data collection. But the data has already been collected for some other purpose and you are using that to make another report or any other new report. That is a secondary data collection. Basically, this is secondary data collection and monitoring. And you use that data and then make other action plans, act on it, and then again continue the monitoring. So this is why it is called surveillance, HIV Sentinel surveillance. Clear? What is HIV Sentinel surveillance? এটার উপর তারপরে শর্ট নোটটা পড়ে নিও বইতে, in part it is clearly written, very well written, so you can study from there also. I have just summarized the points, that's it. What is the next topic? This is Mission Indradhanush. That was related to HIV. Now we are coming to immunization. In immunization, as I said, there is the pulse polio immunization, and then there is the Mission Indradhanush. Now before going to Mission Indradhanush, about vaccination, Mission Indradhanush is a large scale flagship program that is going on in India for the last 10 years. Okay. But before that, there was another large scale flagship program that was going on for years and years, that is pulse polio immunization. Because at that time polio was there in India, wild polio virus infection was present in India, that's why. At that time what happened was, children used to get their polio vaccines on their own time, right? 0 dose, 1 first dose, second dose, third dose, that according to NIS schedule was there, OPV dosage. But apart from that, all the under 5 children at a single point of time were given one dose of polio vaccine, oral polio vaccine. All children at the same time, irrespective of their particular date when they last got or have they even got that polio vaccine. That was called pulse polio immunization. Pulse means at one time for everyone. That is the meaning of pulse. Pulse polio immunization. Why that was done? Because polio was circulated mainly by fecal-oral route, right? Once a child contracted a polio, that fecal-oral route, it is to be transmitted through the environment, etc. So to prevent that, to break that chain of transmission, everyone was immunized with a polio dose at one point of time. The same time everyone was immunized with the polio, so that the transmission is broken. So anyone who is getting the polio virus from a fecal-oral route, the body will be able to fight it with their immunity, the oral polio vaccine immunity. So that was the rationale behind pulse polio immunization, and that also developed the herd immunity, increased the herd immunity. Finally, polio was eliminated from India in this manner only, pulse polio immunization. Nowadays, polio that is circulating, the recent Indian case was last month in I think Meghalaya or somewhere like that. The last polio case was there last month, but that is not a wild polio virus case, that is a VDPV case, vaccine derived polio virus case. Okay, that was a vaccine derived polio virus case, and what happened was that child from OPV only, somehow the virus, attenuated virus, got reactive and caused polio in the child. That what happened in vaccine derived polio virus. If that happens, so that is also circulated by fecal-oral route, right? So in that case, pulse polio immunization is then started in the area. Or if the routine environmental sample surveillance, that is from the sewage and everything, those samples are regularly surveilled and seen whether they contain polio virus or not. If some circulating polio virus is also detected in the environmental surveillance, then also pulse polio immunization is started in the area. So sometimes pulse polio immunizations are started in the regions accordingly nowadays, but the intense pulse polio immunization that used to happen before 2014 does not happen nowadays. So that's why it is a little less relevance nowadays, but Mission Indradhanush from 2014 is more important now, because after polio, other diseases are targeted to be eliminated. The next disease in line is measles rubella. Basically, to target that only, Mission Indradhanush was started. Why? Because up till before that only, the polio coverage in India was not very adequate. It was like 60 to 70% it was coverage, immunization. Especially the measles, you know that in the first dose only is responsible for 85% of seroconversion. 85% people had developed immunity. But on receiving the second dose only, the child had 98% and above immunity, seroconversion. So until and unless they received the second dose of measles, they did not have the full capacity to fight against measles. And the second dose only got missed a lot. Basically, to prevent that and to make everyone get the second dose of measles and also targeted the other vaccine preventable diseases, Mission Indradhanush was started. So it is a Ministry Health and Welfare flagship program to fully immunize 90% of the children who are either unvaccinated or are partially vaccinated. Those who had not been covered during the rounds of routine immunization for various reasons by 2018, previously 2020. Means when Mission Indradhanush was started, the target was in 2014 December it was started, and they are like within 5 years we will cover up to 90% of the children. Fully vaccination means up to 1 year everyone should be vaccinated. All the vaccines that they should receive, they should get all the vaccines. 90% of the children should come under that instead of 60 to 70%. But they reached the target early actually. They reached the target quite early. So it was then changed to 2018. And nowadays, a modified version of Mission Indradhanush is going on. So it was launched in December 2014. Mission Indradhanush has completed 6 phases. The increase in immunization was more in the rural areas as compared to urban areas. Hence, after 2018, what happened? The trend, they saw that the coverage increased in the rural areas more, because there the rural structure of public health is very good actually. From the sub-centers to the, at that time it was sub-center, then PSC, then CSC, the rural infrastructure is very good and the coordination is excellent. But in the urban, it is a different scenario. The population coverage is a lot more than the rural population. The structure was not established yet that much. So the immunization coverage was also, because in the urban areas what happens is a lot of migratory population is there. Okay, people are coming in and now they are shifting their residences all the time because of many conditions. So that's why the coverage remained low in the urban areas under Mission Indradhanush. So what happened is, they, after that, seeing the trend, the ministry then shifted their focus more towards urban slum areas. So then intensified Mission Indradhanush was started targeting those. They saw that 190 districts or urban areas they identified across 24 states, where the focus is urban slum areas with migratory population and districts with slowest progress, and their due list of unvaccinated child were not completed yet. So those special districts were targeted under intensified Mission Indradhanush program from 2017. So after that, what is happening is, now that intensified Mission Indradhanush phase is going on in those districts especially which are lagging behind or in urban slum areas. That is why it is intensified, IMI. Okay. First IMI, 4 consecutive immunization rounds for 7 days in 173 districts of the country every month from October 17 to January 18. So those were given to children who were still unvaccinated in those districts, and now in the latest report, the full immunization coverage is 93.5%. So it has reached and gone above the target of immunization coverage of children. 90% was the target, now it is 93.5%. They are fully immunized, means they have got the vaccines up to 1 year of age. But Mission Indradhanush is again focusing on mainly nowadays MR campaigns, especially MR camps, where the second dose of measles is also being given, so that the seroconversion is complete and they can eliminate the measles disease from India. Okay. So all these diseases that you are seeing, these are the diseases that are targeted for Mission Indradhanush, and recently it was IMI 5th phase with special focus on measles rubella vaccination coverage during August to October 2023. This was the most recent drive. Again, another drive will come, Mission Indradhanush, focusing on those target areas or districts where the vaccination is lower, because it is very easy to go from 60% to 90%. It is very difficult to cover the 90% to 99%. That last phase is always difficult, because then some other issues are there which is preventing that from going to 99%. Those other issues need to be identified and tackled. So it will take a bit of time, but ultimately the target is going above and reaching almost 100%, that all the children should be fully immunized. So this is Mission Indradhanush or intensified Mission Indradhanush. So you have to also mention the diseases that are covered under Mission Indradhanush. That should also be there under your short notes. Okay. Okay. So now we have covered HIV surveillance. We have covered Mission Indradhanush. Next is RBSK. This is under child health. Child health component is RBSK. What is RBSK? Rashtriya Bal Swasthya Karyakram. This is a very old program or scheme. It is basically child health screening and early intervention services. Means the child should be screened up to 18 years. Everyone should be screened for certain diseases and if those diseases are detected, then early intervention should be there. So the protection and health protection and coverage for the children. Free treatment and management also. So if those conditions are detected, then the children will be covered under RBSK and the treatment and management will be made free. Of 4 Ds which are prevalent in children. What are the 4 Ds that are prevalent in children? Defects at birth, deficiency conditions, diseases in children, that is childhood diseases, and developmental delays including disabilities. So all these 4 Ds are covered under RBSK, and these include 30 identified health conditions. There are several health conditions that are identified under RBSK. If a child is diagnosed with that, then their management and treatment becomes free under RBSK scheme. So how they are screened, where they are screened? They can be screened by facility based newborn screening, that is screening of birth defects at public health facilities, especially at the designated delivery points by ANM, medical officer, gynecologist. Delivery point means wherever the child is being delivered. Okay, at the birth only they can be detected. So screening of any birth defects. Referral of birth defects to district early intervention center in district hospitals. So in district hospital there is a DEIC center where they are referred to if any birth defect is detected, like cardiac anomalies. Okay, cardiovascular anomalies like PDA, tetralogy of Fallot and all those things, if they are detected in the childhood, then on the newborns, then they are referred to the district early intervention centers. Okay. And community based screening, ASHAs during home visits for newborn care to screen the babies till 6 weeks of age, because they are going there for postnatal visits. So in that period, if any of the health conditions are detected, they then are diagnosed by the primary physician who is there in the PHC. Okay. Priority to low birth weights, household with chronic illnesses. For checkup by mobile units, line list maintained by ANM and Anganwadi workers used to mobilize children. Means wherever there is no permanent doctor there, the mobile health units, they go by their vehicles. For example, in Anganwadi center there is no doctor, or in sub center or health and wellness center there is no doctor. So when the mobile unit visits, those workers, they will bring the children to the center and then they will be diagnosed by the mobile health units. Okay, so diagnosis and screening is very important. That is the first step. So for newborns, facility based and community based postnatal home visits by up to 6 weeks newborn screening. Now after that, for 6 weeks to 6 years, Anganwadi center based screening by dedicated mobile health teams. Okay, in the children up to 6 years, and after that they will go to school. The children will go to school, right? So for 6 to 18 years, government and government aided school based screening by dedicated mobile health teams. Okay. So all these mobile health teams, or in the newborn and the postpartum stage, the screening by the health workers should detect the disease in the child. So what are the diseases? The defects cover the neural tube defects, Down syndrome, cleft lip or palate, developmental dysplasia of hip, congenital heart disease, congenital cataract, etc. Deficiencies, anemia, especially severe anemia, bite or spots in children, vitamin D deficiency rickets, severe acute malnutrition, goiter. Then childhood diseases like rheumatic heart disease, skin disease, otitis media, convulsive disorders. And finally, developmental delay and disabilities, that is vision impairment, hearing impairment, motor delay, cognitive delay, language delay, any developmental delay, behavioral disorder like autism, learning disorder and ADHD. So if the child is diagnosed with any of the following, this is not all of the 30 diseases, there are many more, I have just mentioned some of them. So if any of the diseases are detected and diagnosed, then they are coming under RBSK and the treatment becomes free. And the treatment mainly starts at the district hospital. Tertiary care center, the intervention centers are there. Okay. So this is the RBSK program. This is for child health. Okay. Next comes the baby-friendly hospital initiatives. Baby-friendly hospital initiative is a new topic, relatively new topic, but it is important for you because it is for the promotion of focus of promotion on breastfeeding. Okay, so it is promoted by WHO and UNICEF since 2018 to improve the infant and young child nutrition with focus on promoting breastfeeding, because it has been found that from the delivery till the discharge of the baby from the hospital, means after delivery the mother is usually kept in monitoring for 48 hours before they are being discharged usually. So during those 48 hours, what intervention or what care should be provided so that the infant and young child mortality especially is prevented. So how it is prevented? Mainly by promoting breastfeeding, but there are other components also. There are 10 components in total that is promoted by WHO and UNICEF since 2018. So there are 10 steps of package of policies and procedures that provide maternity and newborn services that implement to support breastfeeding to prevent infant and childhood mortality. Okay, so there are 10 steps, but you will, once you read through the 10 steps, you will find that they are very sequential. So it might be easy for you to remember. Just remember the sequences from the delivery till the discharge. That is, comply fully with the International Code of Marketing of Breast Milk Substitutes. Okay, means the breast milk, if the mother is not able to have breast milk to feed to the baby, then there should be a standard breast milk substitute that should be available and not any other unapproved product. Have a written infant feeding policy that is routinely communicated to staff and parents. That is, infant feeding policy or infant feeding guidelines should be there in that center, in that hospital, and establish ongoing monitoring and data management system. At first you have to put these systems in place, then only you can formulate the baby friendly hospital initiative. This guidelines or this policy should be in place first. Next, you have to ensure that the staff has sufficient knowledge, competence and skills to support breastfeeding. That the person who is helping the mother to breastfeed the baby, they should know what are the four important positions which the baby should be held, the attachment points of breastfeeding, how the breastfeeding should be done, when the breastfeeding should be done, how the mother should know. The person should have adequate knowledge and skills to guide the mother how to do a proper breastfeeding for the baby. To discuss the importance and management of breastfeeding with pregnant women and their families. Apart from that, apart from having the knowledge and the skill, they should also make the pregnant woman and their family aware how breastfeeding should be done. Because after 48 hours, the mother will go back to her home. There she also has to maintain that proper technique of breastfeeding. So they should be made aware during pregnancy itself, or when the mother is coming to the hospital for delivery. At that time only the person should be made aware. Then facilitate immediate and uninterrupted skin-to-skin contact and support the mothers to initiate breastfeeding as soon as possible after birth. This is called kangaroo mother care. This is also a very important topic, kangaroo mother care. That is, as soon as the baby is being delivered, after that, especially the baby is low birth weight baby, the baby is established on a skin-to-skin contact, uninterrupted skin-to-skin contact, so that the baby does not suffer from hypothermia. The baby and the mother is bonding, and the baby they are establishing reflexes, suckling reflexes also, so that to initiate breastfeeding as soon as possible after birth. Then support the mothers to initiate and maintain breastfeeding and manage common difficulties. Now once the mother is getting the baby after delivery, she has to do the early initiation of breastfeeding, to supporting through that. Do not provide breastfed newborns any food or fluids other than breast milk unless medically indicated. So no other feed should be given. Enable mothers and their infants to remain together and to practice rooming in 24 hours a day. Okay, they should be in the same place, side by side. Even if the mother is very weak, at least the baby and the mother should be side by side, maybe in cot or maybe beside the mother, that is rooming in. Support the mothers to recognize and respond to their infant's cues for feeding. So when the infant is demanding to feed, that the mother should be able to identify that the infant is demanding for breastfeeding. So to help mother with that, that is also under baby friendly hospital initiative. Counsel the mothers on the use and risk of feeding bottles, teats and pacifiers. So what are the other things to which the baby can be fed? The mother should be made aware of that. Coordinate the discharge so that parents and their infants have timely access to ongoing support and care. So coordinate the discharge once the mother has been taught about that, once the mother has been counseled and she knows all the appropriate techniques for breastfeeding and everything, then only the discharge should be done, not before that. Like coordinating the discharge and coordinating the timing of making the mother aware and to make her learn about these things before discharge. So that coordination should be there so that the mother does not get discharged suddenly and the person who was teaching her all those things doesn't know. So to coordinate the discharge accordingly. And other interventions that is important for that child survival include the antenatal care, receiving during pregnancy, clean delivery practices, essential newborn care, immunization and oral rehydration therapy. These should also be there in that hospital so that if any other problems arise, these can be given and the continuity of care is maintained. So this is the baby friendly hospital initiative, BFHI. It is also an important short note. And finally we come to IDSP. This is a bit important because this was started way back, but it is still being maintained and it has been upgraded with time because it is also a surveillance issue like HIV. Only this is under the National Health Mission kind. Okay, the HIV surveillance is under NACO and this is under National Health Mission. This is for the surveillance of other diseases, other communicable diseases. So what is this? How is the surveillance done? It is a decentralized state-based surveillance. Means each state has its own mechanism of surveillance, but they have a uniform guideline on how to do the surveillance, but each state has their own mechanism. Okay, each state has their own staff, appointed staff. These are decentralized. Means all the reporting and all the actions are carried out at the state level. Okay, so it is a decentralized state-based surveillance. It is intended to detect early warning signals of impending outbreaks and help initiate an effective response in a timely manner in urban and rural areas. Earlier it was established so that we can detect the outbreaks in the community early. That's why the IDSP was done. It is a project, not a program, and it was formed. It was a project to see whether this works, whether we can detect outbreaks early. So this mechanism was started as a project. The project was launched in November 2004. It was a 5-year project up to 2010, but the project was then, after seeing the success of the project was restructured and still continues in the 12th 5-year plan with domestic budget as integrated disease surveillance program under National Health Mission for all states. Now it is called integrated disease surveillance program in the government websites, but if you are asked that what is IDSP, you answer integrated disease surveillance project. If someone asks, is it still a project? You then say, no, now it's a program, but it was started as a project. You say in Viva or like that, if someone asks. Okay. So how the surveillance is done? There are 5 steps of surveillance here. Not usually outbreak investigation, it is different from that. I am just saying that how the IDSP does the surveillance. Okay. First step is data collection in the surveillance. Nowadays what happened is, just apart from outbreak detection also, there is a weekly surveillance, weekly collection of data. So weekly disease surveillance data on epidemic prone diseases are being collected from reporting units such as sub-center, PSA, CSC hospital, government and private sector hospitals and medical colleges. Or data collection is done in case of a reported or suspected outbreak in any area. So either some news is coming in that there is a sudden prevalence of some particular symptoms like fever with cough is happening ঘরে ঘরে হচ্ছে, সমস্ত চিলড্রেনের মধ্যে হচ্ছে, খবর পাওয়া যাচ্ছে. So in that case it is launched, or weekly surveillance of certain symptoms under surveillance, they are there under this surveillance data collection. So what is happening? How is the data being collected? They are collected under 3 formats, either S syndromic, P probable or presumptive, and E laboratory formats using the standard case definitions. Means SPE is there, or in some states SPL is there, that is syndromic, probable and laboratory confirmation. There are 3 types of formats, so 3 forms basically that needs to be filled up. Okay, so what are the case definitions? Based on the case definition, these 3 forms are made. Case definition: syndromic. When do you fill the syndromic form? That is when the diagnosis is made on the basis of clinical pattern. The child or the person is exhibiting some clinical symptoms. Based on that, to fill out the syndromic form, S form. If the diagnosis is made on the typical history and clinical examination by medical officer, that is in a center the diagnosis is made, then the medical officer is filling out the probable form, P form. And if the confirmed or the clinical diagnosis by medical officer and or positive lab identification is done, then the person who is doing the lab investigation is filling out the laboratory or the L form or the E form. So there are 3 forms, and any of the 3 forms can be collected. Each of them will contribute towards the data collection. But if the symptom is detected under surveillance, the syndrome under surveillance if detected, they should be filled out in either S form or P form or L form or E form based on where the disease is being detected. কমিউনিটিতে হলে সিনড্রোমিক কি হয়, ঘরে ঘরে গিয়ে আশা যখন জিজ্ঞাসা করে তোমার কোনো কারোর মধ্যে কিছু প্রবলেম দেখা গেছে কিনা, if there is something worth noting, they fill it under S form. Okay, then if it is in the diagnostic, if it is in the medical officer is diagnosing it by clinical examination and history taking, then it is probable, and if it is confirmed by a lab investigation, then it is the confirmed case filled under the E form or the laboratory form. So whenever there is a rising trend in illness, it is investigated by the rapid response team to diagnose and control the outbreak. It is a multi-specialty team of an epidemiologist, clinician, microbiologist and other specialists as per requirement. So when you see in the website, you will see rapid response team of IDSP. State-wise there is a list. You will find people, 3-4 people in every state who are comprising the rapid response team. Whenever there is an outbreak or a rising trend in the particular illness, the rapid response team is informed and they go there and investigate the outbreak. That mechanism is in place. So how the reporting happens? Surveillance is going on, so reporting must also be done, right, of the data. So the peripheral reporting unit or the center from where the data is going, it is sent to the district surveillance unit. That is from the 670 districts. In each of the district surveillance unit is there. From all the peripheral centers, the report is going to the district hospital. From there, they send to the state surveillance unit, and from the state, it goes to the central surveillance unit. And then again, feedback is given to from the central to the state to district and the periphery. It is by this fashion the surveillance is going on. Second is the compilation of data. As you said, compilation of data, and you are sending the data to the surveillance units. Then analysis and interpretation. You are identifying the high risk groups or geographical areas to target and guide the analytic studies, develop hypotheses that can lead to analytic studies about the risk factors. And the follow up with action. What action do? You recognize the case of clusters to initiate intervention and prevent the transmission of disease. What other action can you do? You can share the surveillance information, you develop partnership with the other health and non-health sectors who are involved, include the communicable, non-communicable disease in the surveillance system, effective partnership of private sector and NGOs, and bringing academic institution, medical colleges also into the mix. So you involve everybody and then enhance your surveillance system so that from everywhere the data can come in and we can effectively monitor the trend in the disease outbreak or any disease prevalence. And finally, the feedback. Monitor the effectiveness of prevention and control measures. Whatever prevention and control measures the rapid response team is providing, you monitor that. Assess the public health impact of the health events and demonstrate the need for public health intervention program resources and allocate resources during public health planning. So from the center only it trickles down, the feedback trickles down, and all the help is allocated towards any area that is seeing an upward trend of the disease. So that is there. So this is in the public health sector, all these centers are involved in the disease surveillance, and in the private health sector all these are involved, like Sentinel private practitioners and nursing homes and everything. And in the public health sector, the government sector, all these things are there, all these levels are there from where the surveillance is going on. Finally, what are we looking for? The syndromic prevalence that is there, what are we looking for? Usually for every weekly data that is going to the surveillance units, fever is under surveillance. What type of fever? With less than 7 days of duration without any signs, fever with rash, fever with altered sensorium or convulsion, bleeding from skin or mucous membrane, fever more than 7 days without localizing signs. So fever with anything, if there, it is noted down and then reported in the syndromic form. Then if cough more than 3 weeks duration, acute flaccid paralysis in the child, diarrhea is there, jaundice is there, or unusual events causing death or hospitalization. So whenever you go to a center and ask that this IDSP report that is going to the center, the surveillance unit, how many fever cases were detected, how many diarrhea cases were detected. So they have a list of every week. Even they at the end of each month they do a monthly consolidation of data and they update that also. So that is reporting is going every week and every month from the center to the higher ups. That surveillance is always there. And in case of an outbreak, what all are warning signs? That is wanting the needs of an RRT, that is rapid response team, to come to that area. What are the warning signs? There is a clustering of cases of deaths in time and or space, means somewhere a lot of deaths have occurred suddenly or cases have occurred suddenly. Unusual increase in the number of cases or deaths. Even a single case of measles, AFP, cholera, plague, dengue or JE, if it is reported in any area, the rapid response teams have to come to that area. Then acute febrile illness of unknown etiology. Occurrence of 2 or more epidemiology linked cases of meningitis, measles. Unusual isolate, shifting in age distribution of cases, means cases that used to be happening in children are now happening in adults. If that is found, then also the rapid response team is deployed. Then sudden increase or high vector density in case of vector-borne disease and in case of natural disaster. So also in natural disasters and situations, there is a high chance of infectious disease spreading out, right? So there also the IDSP team have to be there to prevent or implement the measures to prevent that from happening. So these are the functions of IDSP. This slide is very important. This needs to be mentioned in the IDSP short note. And this slide also, the syndromes under surveillance. In IDSP, these two parts need to be mentioned and other parts can be mentioned in brief, but these parts need to be mentioned in details.